if I'm looking at a lesion from an animal or from a person microscopically, and I see these changes under the microscope, then I'm gonna say, oh yeah, this hasn't been going on that long. This is more of an acute reaction. You know, if I don't even know the time frame, if I just see that tissue microscopically, I'm looking for these telltale signs. So if I'm seeing edema in the tissue, if I'm seeing a predominance of neutrophils at the site, and what duration am I going to put on that? Acute duration. Even if I didn't know how long it is taking place. If I see that microscopically, that's a pretty good sign that this is a short, you're going on a pretty short time. Yes, sir?
So microscopically, you're talking about like basically the tissue or the site of inflammation, right?
Yes.
So whenever we evaluate circulatory or systemic blood flow, and we're looking at the cells in there, you would expect a decrease in some of those because of the sudden shift of cells from the blood vessel circulation to tissue site.
A decrease in circulating blood, white blood cells is what you're saying?
Yeah, or does that happen in the chronic phases where you depleted so many of them?
Yeah, well, you know what? There's a pool of leukocytes there, you know, that may not be actively, but they just circulating around. And so you're not going to see any very dramatic changes unless they've been pulling them out over a period of time. Initially, they'll show up at the site, but they got a lot of reserve, big reserve pool of them. So you're not going to see any dramatic changes in the numbers of them unless it's something that's ongoing, constant, drawing them out there in circulation. And then the bone marrow is still going to be making more of them anyway.
So that leukocytosis and that neurophilia that you get with acute phases, is that from the cells coming from marginal pools and the bone marrow?
Not so much the bone marrow initially, but the marginal pool. Those that circulate within the blood vessels. Not all of them are showing up. Some of them are like adherent, and they translate here and get back into the bloodstream. So you got a number of them that's already there, but as soon as you got the signal calling them to bring out those neutrophils from the bone marrow, they will do that too. But they pretty much have enough circulating around to handle it. But if it's ongoing, you're going to get a response in the bone marrow, and they'll replace the one as well. So it's a good question. Yeah, but yeah, they're not going to be depleted to the point where my bone marrow is suffering now. Man, like no. You're going to have enough out there to circulate marginally, and then the bone marrow will kick in if it's over any period of time. You get some recruiting from the bone marrow out there as well. So you don't really see a big deal, a major shift in them. Yes, ma'am.
So, like, I know that when you have like this accumulation of neutrophils, you can also see pus, but you wouldn't see it with acute. You would just see it over time because the neutrophils are releasing all their, I guess, like their cytokines and all that.
Yeah, no, good question again. I mean, yes, the accumulation of those neutrophils there, some of them gonna die off and release their products. After they release those enzymes, the lysosomal enzymes into the site, some of them will die off there as well. And so all those dead neutrophils will constitute pus, separate type of reaction. So yeah, but just if there's a whole lot of pus that's being produced, eventually the body kind of make a wall around that, and you get an abscess. An abscess is like a wall around that pus. But an abscess would be more of a chronic process because you got that connective tissue wall surrounding it. Now, I just told you neutrophils are the ones that are out there, the earlier cells out there, right? So acute inflammation, when I see neutrophils, when I see pus, I'm thinking acute. Right, but now, if you progress to the point where there's a lot of neutrophils out there and they're dying off, and then the body says, hey, let's need to close these guys off. Let's form a capsule around all these dead neutrophils there, which is surrounding this dead bacteria or dying bacteria. So you form that dense capsule around it, forming an abscess. Then you can, despite the fact there are a lot of neutrophils there in pus, you can't call that an acute process, because it takes time for the wall to develop around that collection of pus, in that case. Yeah, I mean, so you can have pus at the site and it still be acute, but you can have pus at the site you got a wall, an abscess wall around it, then you're gonna call that chronic. If you wanna be technical about it, you would call that what? Chronic active. Because you got elements of acuteness there, and you got elements of chronicity there with that dense fibrous connective tissue wall around it. Okay, so here again then, so when you talk about acute inflammation, particularly as it pertains to cells, you're gonna get those neutrophils out there first. You'll show up first, they're actively motile, okay, and they're just fast swimmers, if you will. Okay, they get there and they respond to certain symbols, chemotactic signals. We won't get into all that later on, all right? But they respond quicker, they're actively motile, intensely phagocytic, and releasing of those lysosomal enzymes at the site. So they're the first cells there generally. And as I said, there are exceptions to that. Okay, the subacute inflammation, we're talking about inflammation according to duration now, right? So there's going to be a decreased vascular contribution here in this case. Okay, so edemas kind of go down, you're not going to have all that. May have some swelling there still residual, but you're going to get a decrease in the fluid component with subacute inflammation. A decrease in the redness, because the vascular changes are going to be congested, red blood vessels, so the whole site is going to be red. It's going to increase blood flow to that site. Okay, so, but in subacute, it's going to be kind of more dull color, a diminishing of the red color that you saw with acute inflammation, diminishing of the swelling edema fluid that you saw. Other cell types are going to show up there, like lymphocytes, macrophages, a few plasma cells may show up there as well. There's a decrease in neutrophils there. So not that they're all gone, but there's a diminishing in the neutrophils and some more of these, what we call mononuclear cells. These cells have one nucleus in contrast to the PMNs, the neutrophil. And so these lymphocytes, macrophages, and plasma cells, all of these have singular nuclei, and so they're referred to as mononuclear cells. So with subacute inflammation, you're going to have a little increase in mononuclear cells showing up, a decrease in PMNs, polymorphonuclear cells are there, a decrease in the vascular component, so it's not going to be quite bright as red, a decrease in the swelling, so it's not going to be, not going to have a whole lot of edema fluid associated with it. So now I see that, I see at the inflammatory site, this picture, and I'm thinking, no, it's not, that didn't happen like a couple hours ago. This happened for a period of time. This is subacute inflammatory process. So nobody ever told me, oh, that happened, a day ago. I mean, I could look at that microscopically and say, nah, it didn't happen, 8 hours ago. This is a little longer than that. This happened probably beyond 5 hours. Okay. So, so you can tell, get some idea about the duration by looking at things microscopically as well.
Did you say increase in macrophages?
Yeah, you'll see them macrophages, lymphocytes, plasma cells, they're going to kind of increase in number. Neutrophils are going to diminish in number. They'll still be there, but the bulk of the cell types are going to be mononuclear cells in subacute. Okay, now what about that chronic inflammation? Characterized by fibrosis and mononuclear cells. So now, just a diminishing of the neutrophils more and more in the chronic phase. A diminishing of neutrophils more and more in the chronic phase. So this is usually due to a persistent stimulus, something that the body has really got rid of. Neutrophils, so let's just say a bacteria invaded, neutrophils left the blood vessels and got there, tried to destroy that bacteria, but the bacteria is a bad bacteria. And so he said, I'm not going anywhere. And he's fighting off the neutrophils too. And so it kind of stays around. And so more of the mononuclear cells come out there, try to destroy that particular bacteria, for example. Still kind of ward that off as well. So it kind of stays around, and you got more of a persistent stimulus there in chronic inflammation. It may begin, though, as a low-grade smoldering response. Like, again, with prion diseases, is my example of that. By the time we see a prion disease, like scrapie or mad cow disease, by the time we see that, we see elements of a chronic inflammatory process. And so the question is, it began as a low-grade, under-the-cover type of inflammatory process from the beginning, or was that neutrophils there at one point and they just subsided to these mononuclear cells, right? So not quite sure about that, but some of them may begin. By the time we detect it, it's already at this point of being a low-grade, smoldering response with signs of chronicity there by the time we detect it. So we don't really see a acute, subacute, chronic phase in some of these diseases. By the time we see them, they're like at a chronic phase. So fibrosis is a major criterion on this one. The star underline that one. Fibrosis is a major criteria, and mononuclear cells are prominent. So that doesn't mean you can't get one or two neutrophils around, right? But the predominant cell type in this one is going to be the mononuclear cells. What are the mononuclear cells now? Lymphocytes, plasma cells, macrophages, right? Okay, so fibrosis is a major criteria though, because you can see those same mononuclear cells in what kind of inflammatory process? Subacute, right? You begin to see them in subacute. So what's going to distinguish subacute from chronic?
Fibrosis.
There you go, fibrosis. So fibrous connective tissue is going to be laid down in chronic inflammatory process. So if you got chronicity, evidence of fibrous connective tissue, and you have evidence of acute inflammation, like the neutrophils and the pus, that scenario, then you're going to call it based upon the ones of lower duration. So chronic would be the process. You could say chronic active, and you wouldn't be out of the ballpark either. But if you want to differentiate from acuteness and chronicity, you're going to go with the one that's for longer duration, and when you name it. And so later on, we're going to name inflammatory processes. Yes, sir?
So would it be safe to say in the chronic stages, you can expect to see an increase in on a histological exam, fibrocytes and fibroblasts also then?
Yes. Yes, fibroblasts, fibrocytes, and not only that, collagen that they lay down. They make fibrous connective tissue, or collagen fibers. You expect to see that as well. Yeah. Okay, so what's our definition of inflammation? The vascular and cellular response of living tissue to injury. Can't get dead inflammation. Right? Body's dead, no reaction is happening. Nothing's happening to the blood vessels. So you can, injure it as much as you want to. Y'all wonder how the people, forensic scientists determine whether or not was that the knife wound that killed the patient, or was this one? What are they looking for? They're looking to see whether or not there are reactions. I mean, if the person was still alive, or the animal was still alive, the cause of inflammation, right? There's going to be a vascular and a cellular response of that tissue to injury. So anytime there's injury, there's a reaction, a telltale sign. So you have 10 stab wounds, and 2 or 3 of them associated with an inflammatory response or reaction, then you know that was an antemortem injury versus the other wounds, gunshot or stab wounds without any reaction around them, then likely those will be the ones that occur after the death of the individuals, as a somatic death, okay? All right, so the vascular and cellular response of living tissue to injury, this is a blood vessel here, and look at the surrounding, all this will be the surrounding connective tissue cells here. There are mast cells out there, there are fibroblasts out there normally, there are a few tissue macrophages out there, normally, okay? What are those macrophages in the liver that's normal residents of the liver? What do they call it?
Kupffer cells?
Yeah, Kupffer cells, right. So they're normally there, but they're not undergoing any kind of change. I mean, they can be stimulated to proliferate and join in the inflammatory process. But the majority of cells at an inflammatory site be it in the liver, lung, kidney, wherever it is, are gonna be cells that's gonna leave the blood vessels in that site. You may have a few cells that are there, like here's a macrophage out here, tissue macrophage.
Histiocyte?
But guess what? Histiocytes in the skin, I thought somebody said, yeah, so those would be normal macrophages in the skin, but they're not doing anything. They just, well, they're doing something, but they're not a part of an inflammatory process. Okay? In the bulk of those inflammatory cells, mononuclear cells, as well as PMNs, the bulk of those cells are going to come where? From the bloodstream. From the bloodstream. Okay? The ones out here, outside of the vessels, that are normal residents of the tissue, may be there. Normally, without reacting to anything. They're there. You know, macrophages could be antigen presenting cells, we know that, but as far as the inflammatory process is concerned, they're not being involved in an inflammatory process. And when this tissue is disturbed, you may get a little activity there with those, but the bulk of those macrophages is going to come from here, the bloodstream, from these cells, which are what? Monocytes, is going to be transformed into macrophages once they leave the blood vessel. All right? So here again, you got a blood vessel with all these cells in here, and you got an injury somewhere out here. So it stands to reason that you got to get these cells outside of this blood vessel over here to the site of the injury. The injury is here, in the connective tissue, and you got to get these elements out of the blood vessel into the tissue spaces. All right, so what's in the connective tissue, again, mast cells, you have fibroblasts, which lays down collagen, fibrous connective tissue, and you have elements of fibrous connective tissue out here, such as collagen fibers here, right? Maybe the elastic fibers right through here, proteoglycans. All this is a part of the matrix, the extravascular matrix. Okay, and they all play a part in the inflammatory process, believe it or not. Okay, so it's the role that the cells play, the role that the blood vessels play. And look at the blood vessels, you got all these clotting factors, you got kininogen and complement components, which you're going to find later on is going to be involved in the inflammatory process. Okay, so all these within the blood vessel though. So they got to get out of here in order to stimulate or facilitate the inflammatory process. And you got the same thing with these PMNs, lymphocytes, monocytes, eosinophils, basophils. They got to leave the blood vessel to get to the site. Okay, so this is the environment then of the inflammatory process. This is the environment. Yes, sir.
So yesterday you had asked us about what it takes for a clot to form, right?
Yes.
So right now we're talking about inflammation in the tissue, but you can also have like inflammation with intravascular inflammation.
Yep.
So
yes.
Is that one of these same processes where it predisposes the patient to a hypercoagulative state?
Well, yes. Mainly when you damage, say, the blood vessel wall, vasculitis, for example. You talk about vasculitis, the inflammatory process involved in the wall. Let's say it's a viral infection that sort of damages the wall, like a herpes virus, for example, or bacteria, erysipelas they mentioned yesterday in show and tell. But then these cells are within the bloodstream here. They're gonna reach that site there of damaged wall due to the bacteria. Bacteria damages this wall, so you're gonna get platelets. You're gonna get these leukocytes in here, PMNs. All those gonna gravitate to that site within the vessel. And guess what? Some of it will spill out over here, outside that vessel there as well. You're going to get that, and then yes, it will change the components that's in the blood here. All right, so you got all these blood factors here, complement. You got coagulation factors there in the blood. All that's going to contribute to that. So if you damage this wall, you're going to interfere with blood flow, right? As the clot kind of enlarges. So you're going to, and then as you said, if it's inside of this vessel, you're going to have some changes in these clotting factors here, as far as increased amount, and that's going to facilitate a hypercoagulable state in that vessel as well. So you can get all three of them. The damaged intima here, all right, And then the collection of these inflammatory cells at that damaged site form like a little imagination into the lumen there, and that can, you can see how that can interfere with blood flow. And so all three of them could be present in the case of a vasculitis. All three elements could be certainly present. They are contributing to the thrombus that will form in living tissue. So yes. But I just want to show you here just this whole, this milieu, or the environment in which inflammation takes place. All right? But there's the wall of this blood vessel here, or out here in the tissue. Okay, so look at the components, non-cellular components, collagen, elastic fibers, proteoglycans, and then the cellular components, mast cells, fibroblasts, macrophages, will be the main ones out here, and then look at the vessel, blood vessel. And see, also, within this inflammatory process, not just the circulating vessel, but the endothelium is going to be active in this process by causing contraction and relaxation of endothelial cells, allowing leukocytes to go between the endothelial cells to get out to the tissue. We're going to get in all of that. We don't get ahead of ourselves here. Okay, so I want to leave you with these generalities about inflammation. Okay, 10 generalities about the inflammatory response here. First of all, it is a process involving multiple participants. That's why we call it Operation Heavy Thunder. The big guns, the little guns, everything is brought to bear at that site when there's injury. So it's a process involving multiple participants. I just showed you that slide with the blood vessel coursing through the tissue. You got cells inside the bloodstream, cells and tissue outside the bloodstream. Okay, you got factors that's going to be created or generated in this process. You got enzymes that's going